So, ladies and gentlemen, we will begin the event. Thank you for joining us today to celebrate this special occasion. My name is Hae-jin Jung from the Korea Foundation for International Healthcare, or KOFI. It is my great pleasure to briefly introduce KOFI, the host of today's event, and to share with you the purpose of our gathering. The Korea Foundation for International Healthcare is a public institution committed to promoting global health and strengthening health systems around the world. So today we come together to honor the legacy of Dr. Lee Jong-uk, a pioneer in public health, and to recognize outstanding contributions made in advancing global health through the Dr. Lee Jong-uk Memorial Prize for Public Health. We sincerely thank the Geneva Health Forum for their invaluable support in organizing this event and for being an essential partner in facilitating dialogue and innovation in the field of global health. Now, let me take a moment to welcome our host for today. Dr. Il-Soo Ha is the president of KOFI and a leading figure in advancing global health initiatives. Dr. Ha has been instrumental in shaping KOFI's vision and expanding its global impact. He is an emeritus professor of pediatrics at Seoul National University, specializing in pediatric nephrology. Dr. Ha is recognized for his expertise and leadership in international healthcare cooperation, including major projects in Uzbekistan. It is under his leadership that KOFI has continued to honor the legacy of Dr. Lee and to champion initiatives that bridge gaps in healthcare access around the world. Now, please join me welcoming Dr. Il-Soo Ha to deliver the opening remarks.
Dr. Margaret Chan, former Secretary General of World Health Organization, His Excellency Khoi Vani, Secretary of State, Ministry of Health of Cambodia, Dr. Jerome Kim, Director General of International Vaccine Institute, Dr. Juno Choi, Director General for International Cooperation, Ministry of Health and Welfare of Republic of Korea, Dr. Soraya Dalil, Director of Special Program on Primary Health Care, WHO. Distinguished guests, esteemed colleagues from WHO, South Africa, and Republic of Korea, whose names I cannot list here because of the limited time. And above all, this year's laureate, Dr. Helen Rees. It is a great honor to welcome you all to this laureate lecture, co-organized for the first time by Korea Foundation for International Healthcare and Geneva Health Forum, made possible through the kind collaboration of Professor Ang Tuang Flo and Dr. Eric Comte. Dr. Rees is a globally respected leader and advisor in public health, widely recognized for her exceptional contribution to vaccines, infectious diseases, and reproductive health. As we are constantly reminded, global health faces increasingly complex and evolving challenges, and this requires evidence-based decision-making, timely action, and brave, strong international collaboration and leadership. In this context, insights and achievement of Dr. Rees are more relevant than ever. Alongside the valuable perspectives of our distinguished panelists, I believe that today's lecture and discussion will not only inspire us, but also help shape and guide our collective efforts in addressing the global public health challenges we have. Once again, I extend my heartfelt congratulations and deep appreciation to Professor Rees for her lifelong dedication to advancing public health. Thank you very much.
Thank you, President Il-Soo-ha, for your thoughtful welcoming remarks. Now we will proceed with a series of congratulatory addresses from distinguished representatives of the global health community. First, it is my honor to introduce the Minister for Health and Welfare of the Republic of Korea, Cho Kyu-hong, who will share a message of congratulations and Korea's commitment to advancing global health. He will deliver the message virtually. Please welcome him with a round of applause.
안녕하십니까. 대한민국 보건복지부 장관 조규홍입니다. 이번 이종욱 기념 공공보건상 수상자 기념 포럼에 참석하시어 자리를 빛내주신 WHO, 주 제네바 남아프리카 공화국 대표부, 주 제네바 한국 대표부 관계자 여러분께 감사의 말씀을 드립니다. 또한 이 행사를 준비하느라 수고하신 한국국제보건의료재단 관계자 여러분께도 감사드립니다. 특히 오늘 포럼에는 마가렛 찬 전 WHO 사무총장, 지영미 대한민국 질병관리청장, 제롬 킴 국제백신연구소 사무총장을 비롯하여 국제보건 분야를 선도하는 전문가 여러분께서 함께해 주셨습니다. 이종욱 박사의 정신을 기리고 공공보건의 미래를 논의하는 자리에 함께해 주셔서 진심으로 감사드립니다. 이종욱 기념 공공보건상은 전 세계 질병 퇴치와 인류 건강 증진에 평생을 바친 제6대 WHO 사무총장 고 이종욱 박사의 헌신을 기리기 위해 대한민국 정부와 WHO가 공동으로 제정한 뜻깊은 상입니다. 오늘 이종욱 공공보건기념상을 받으시는 남아프리카 공화국의 헬렌 리스 교수님께 진심 어린 축하와 격려의 말씀을 전합니다. 이 자리가 아프리카 지역의 보건의료 환경 개선에 크게 기여한 교수님의 탁월한 업적과 헌신을 널리 알리고 앞으로도 행보를 이어가시는데 큰 힘이 되는 소중한 계기가 되기를 바랍니다. 대한민국은 앞으로도 글로벌 중추 국가로서 국제적 위상에 걸맞는 역할과 책임을 다하기 위해 노력할 것입니다. 또한 전 세계 공공보건 수준 증진을 위하여 WHO를 비롯한 보건의료 분야 국제기구 및 회원들과 긴밀히 협력해 나갈 것입니다. 이번 행사에 참석해 주신 모든 분들께 다시 한번 감사드립니다.
Thank you, our Minister, for your inspiring message. So next, we are pleased to welcome the representative of the Republic of South Africa, who will deliver a congratulatory address. So Dr. Precious Malebuna Machoso is a distinguished leader in public health and former Director General of the National Department of Health. Dr. Lee was the one who appointed her as a director in WHO, so it's very meaningful. She was the INB of pandemic agreement, which was just approved 3 days ago, so big achievement. With her exceptional expertise and visionary leadership, Dr. Machoso is perfectly positioned to offer heartfelt congratulations to our laureate. Dr. Machoso, please step forward to deliver your congratulatory remarks.
Good afternoon. It is truly an honor and privilege to congratulate Professor Helen Rees, a globally recognized, nationally revered, and regionally admired leader. A leader of note in public health, a leader of outstanding recognition in regulatory science. Some of you may not know that Dr. Rees has transformed lives, and he's called upon at every minute. He's relied upon by government of South Africa. He's been recognized by the president of the country and has received outstanding awards. But it's been Dr. Rees who went into the trenches and changed lives of women in South Africa. It is Dr. Rees who led the vaccines program in the African region. But it is the same Professor Helen Rees who has been at the forefront of SAGE. Dr. Rees, who has led fights against pandemics. In fact, the Wits University has recognized her contribution in global health for the past 14, 15 to 30 years. I have personally worked with her as my chair of the Medicines Control Council, but I've also worked with her in the institutions that we work for. But of note is her contribution to the work in WHO. In fact, I always ask, when do you get to sleep at home? Because do you work at the airport? But it is just her contribution where she consistently and steadfastly work and contribute to change lives, and in particular, women's lives. It is an honor and privilege to be the one recognizing you from our country. I thank you.
Thank you, Dr. Matoso, for your encouraging words. Wow. Yeah. Now we are honored to invite the representative of the World Health Organization, who will offer congratulatory remarks and reaffirm WHO's leadership role in shaping the future of global health. Dr. Soraya Dalil serves as the director of the WHO Special Program on Primary Health Care, which Dr. Lee was very emphasizing. Throughout her distinguished career, Dr. Dalil has been a tireless advocate for equitable access to health care and has played a leading role in strengthening health systems, particularly in low and middle-income countries. Her commitment to primary health care as a cornerstone for achieving universal health coverage reflects the enduring values championed by Dr. Lee Jong-wook. We are truly honored to have her with us today. Please join me welcoming Dr. Soraya Dalil to the stage.
Hello and good afternoon. Distinguished delegates, dear colleagues, dear friends, Mr. Il-Soo Ha, President of COFI, Dr. Motsoto, dear Dr. Margaret Chan, good afternoon again. I would like to thank the Korean Foundation for Healthcare on behalf of WHO Director General for organizing this event. It's my pleasure to be with you today to congratulate Professor Helen Rees as this year's honorable recipient of the Dr. Lee Jong-wook Memorial Prize, a prize that honors the memory of Dr. Lee Jong-wook, who was the Director General of WHO 20 years ago from 2003 to 2006. From the WHO Special Program on Primary Health Care, we are thrilled to acknowledge Professor Rees' lifelong commitment to the health of communities that are most in need, with a strong focus on improving equity and access. Professor Riss, we extend our sincere congratulations to you for your exemplary dedication to public health, to primary health care, to innovation, and to equity. In South Africa, you have been designing and piloting novel approaches, proving concepts, and scaling up at the national level and beyond. Your commitment to equity is exceptional, focusing on the most marginalized communities, famously in the Hillbrow Health Precinct. Your scientific contributions are outstanding, covering childhood immunization, HIV, TB, COVID-19, to name a few. Importantly, you have taken every opportunity to use this experience to help shape national, regional, and global directions on tackling these diseases, making an impact at a larger scale. More people are living healthier, more fulfilling lives because of your passion and because of your accomplishments. Your scientific excellence is also well recognized. WHO and other international organizations benefit from that through your expert contribution to multiple international advisory bodies. You are a true health champion that we can all learn from and look up to. Equity is at the heart of the primary healthcare approach. Primary healthcare is the most effective, efficient, and equitable approach to improve people's life, health, and well-being. We need to continue to build a global community of PHC champions, and that's why I'm particularly excited that WHO is working closely with the Korean Foundation of International Healthcare on enhancing PHC leadership capacity in countries. This week, World Health Assembly is gathering around the theme of One World for Health. This week has been eventful with a strong focus on primary healthcare approach as critical to achieving universal health coverage and health equity. We have heard that in many statements from member states in the plenary and the two committees this week. Indeed, the adoption of the pandemic agreement is a major milestone for the multilateral cooperation of our time. We are delighted to recognize health champions and all those who contribute to health for all, such as yourself, Professor Riss. You have set an example of excellence and compassion over 4 decades of relentless efforts. We know that you will continue and reach further with your remarkable work, and we hope others will follow in your footsteps to achieve equity and health for all through primary health care. Thank you very much, and I wish you all the best.
Thank you, Dr. Dalil, for your meaningful and inspiring message. Now we move on to the highlight of today, the laureate lecture. I would like Professor Antoine Flahaut from Geneva Health Forum to introduce our honorable laureate for 2025. Professor Flahaut is a renowned epidemiologist himself and public health expert, currently serving as director of the Institute of Global Health at the University of Geneva. With decades of experience in disease surveillance, pandemic response, and international health collaborations, he is widely recognized for his leadership and insights in the field of global health. Please join me welcoming Professor Flahaut to the podium.
Thank you for your kind words, Mrs. Young. Each year, the Dr. Lee Jong-wook Memorial Prize for Public Health recognizes an individual who has made outstanding contribution to advancing public health and embodying the spirit and dedication of Dr. Lee Jong-wook. I thought it was a secret. I've been told it is a secret. Nobody should know the name. I thought I would have had an envelope and I would have disclosed it and said, it is with great honor that I introduce the winner of the year, Dr. Helen Rees. Dr. Helen Rees is a renowned global health leader and a tireless advocate for public health, with a career spanning decades of service in the fields of infectious disease, vaccine policy, and reproductive health. As a founder and executive director of the WITS Reproductive Health for HIV Institute, the WITS RHI, at the University of Witwatersrand in South Africa, in Johannesburg, Dr. Rees has played an instrumental role in advancing scientific research, shaping global health policy, and improving the lives of millions through her work on HIV, prevention, vaccine development, and women's health. Her leadership and commitment to evidence-based public health action perfectly reflect the values that Dr. Lee Jong-wook championed throughout all his life. We are deeply privileged to hear directly from her today. Ladies and gentlemen, please join me in warmly welcoming Dr. Helen Rees to deliver the laureate lecture entitled Caps and Gowns, Activism and Evidence in Public Health.
Good afternoon, everyone. Well, to all the honorable delegates who are here, all the friends and the colleagues, to my family, thank you very much. I'm deeply, deeply honored to receive the Dr. Lee Jong-wook Award, the Memorial Prize for Public Health. It is something when you walk through a career, you don't have an ambition at the end to say, I think I'll get a prize. But when you get it, it's actually wonderful. I'd like to say thank you very much to the Geneva Health Forum for hosting this, and to Kofi, thank you very much for for considering me for this award, but also for your warm introduction. I'd also like to say thank you to the Minister for his kind words, and to Soraya from WHO, and Precious Mutsotso, who you heard, who has just chaired, as you heard, co-chaired the pandemic agreement. You might just, I'll say in brackets for Precious, she is a good friend of mine. So you have to take a pinch of salt with some of the nice things that she said. So in terms of this lecture, I decided to talk about activism and research and evidence in public health. And the reason for doing that is that I think for many of you who are involved in public health, you will know that we have to have research and we have to have evidence. But many people will argue that actually to be in public health, you also have to be an activist in some shape or form. This was what I was asked to do. The laureate speech should highlight your achievements in public health, particularly in the area of infectious diseases. I would rather give a scientific plenary than write this. This has caused me sleepless nights. It's very difficult to look back on your career and write something that covers the whole ambit of what you've done with a focus on infectious diseases, but also in a focus on activism. So I hope I capture this for all of you. I went back to this definition of health, and this is from the World Health Organization in 1946. You're all familiar with it, but it's worth looking at it again because I think it was prophetic. Health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. The enjoyment of the highest attainable standard of health is one of the fundamental rights of every human being, without distinction of race, religion, political belief, economic or social condition. That is a profound definition and goes much more, it goes way beyond individual patient health. I then looked up health activism, and that's a newer concept, so I went to AI. Health activism aims to create more equitable and supportive environments for individuals and communities to achieve optimal health. This can involve a wide range of actions, from direct service to advocating for policy changes by challenging power structures and systems that negatively impact health and health promotion. So I went back and I thought about what had influenced my career and my life, and I went back to the book Outliers by Malcolm Gladwell, which I'm sure many of you have read, and came up with some quotes. And the first one was, it makes a difference where and when we grew up. And if I said this to everyone in the room, you would agree with this if you looked at your own careers and your own lives. So the picture on the right-hand side at the bottom, my parents, my sister, who's here, and I understand many of you have been congratulating her for getting the award today. It's me, not her. But the influence here was that my father came from the Welsh coal mining valleys. His father was a coal miner and his grandfather was a trade unionist. So through him we had a sense of social justice and a belief in organized labor, but also a sense of what it means to come out from poverty. My mother came from a Welsh rural area, a father who was a preacher, a Methodist preacher, but also a headmaster. So a very strong belief in education. And from the two of them, they framed a belief in education and a desire from my mother to go into medicine. Then the next quote from Malcolm Gladwell is that we are all beneficiaries of some kind of unusual opportunities. You think back, you'll recognize this. So I did go into medical school in Cambridge, and this was in the 70s. At the beginning, there was a very strong belief in women's liberation movement that was going on there, and this was a protest. Well, it was in support of women's rights. In those days, you had to go to London to do your clinical training, and there I got involved with a movement for homeless people to stop the demolition of Victorian houses so that homeless families could actually get occupation. Also at the time, in the 60s and the 70s, was the anti-apartheid movement. There was a Springbok tour to the UK, and there was a lot of protest there, and I became also involved in the anti-apartheid movement. I did manage to finish my degree, however, and also did a master's thesis in social and political science. And this was the first time that I focused on really a health question, which was looking at maternal and neonatal outcomes after induction of labour. But then, opportunity. I went to do my student elective in a small Welsh mining village called Glencorrwg. Some of you will have heard of Dr. Julian Tudor Hart. He was a man ahead of his time. He was a GP in the small village, but he also undertook research. And his belief is beautifully summed up here. Medical services are not the main determinant of mortality or morbidity. These depend most upon standards of nutrition, housing, the working environment and education, and the presence or absence of war. And never could that be more true than today in terms of what we're seeing in terms of conflict. He wrote a really incredibly important paper right back in the Lancet, but in 1971, and it was called the Inverse Care Law. And what he argued was, and he saw in the village where he worked, was that the socially disadvantaged populations receive less health care than socially advantaged populations. And if you look at the dotted line at the top, that is need. And you look at the solid line at the bottom, that's the availability of resources and health services. And the people with the greatest need often get the least resources. The third thing I'm going to quote from Malcolm Gladwell is something he calls lucky breaks. Now, you might recognize this person afterwards. This is my husband, Faisal. And the reason I'm highlighting him is because I met him, and I remember I was very involved also with anti-apartheid thinking. He was from South Africa. He had come to the UK to do his medical training. And meeting him meant that my direction in life then changed to Southern Africa. He and I went to Zimbabwe, and immediately after independence, where I was a pediatrician in Harare Central Hospital. what we saw there was the inequality that had been inherited in Zimbabwe for years prior to independence. This was another colleague who I worked with, less known than Dr. Julian Tudor-Hart. His name's David Saunders, and he wrote many publications about primary health care. And in one of those publications, The Struggle for Health, he said healthcare workers should expand their work beyond medical care and address the social determinants of health and issues of social justice. And he also emphasized the importance of primary health care, which I think we would all now echo. But at the time, in the 70s and 80s, wasn't such a well-recognized concept. So working as a pediatrician, what we were seeing was huge amounts of malnutrition and diarrhea and children dying. The weaning diet there in Zimbabwe at that time was a water-based porridge based on sadza, which meant that there was very little nutrition for children being weaned. We're also seeing large amounts of vaccine-preventable diseases. So what did we do? This is, if you like, the first time I experienced appropriate technology. So we recommended adding high-energy, protein-rich, locally available groundnut oil to the sadza. We took the common orange that was probably the only orange squash bottle that was available then in Zimbabwe, and we added water, sugar, and salt in specified quantities, which stopped a lot of dehydration and deaths from diarrhea, and widespread vaccination campaigns made a huge difference. But then Faisal and I went from there into South Africa in the 1980s, where really South Africa was a place on fire. The youth were revolting in the townships. There was a lot of deaths and assassinations. And this was a picture at a funeral of a colleague who I worked with, looking after detainees who had been tortured. And this is where I think the activism in health comes in. So at the beginning of the 80s in South Africa, an organization called NAMDA was established, the National Medical and Dental Association. It was an anti-apartheid structure. It had about 1,000 doctors and dentists working in it who were opposed to the apartheid state. We established, as I mentioned, a detainee support committee for detainees who've been tortured in detention. The first grant I ever got was to set up an emergency services group for youth in townships who were being shot, were being frightened and persecuted. And what we did was train them in emergency first aid, and we gave emergency equipment. We wrote a report to Amnesty International about what was happening. And I was involved in bringing an interdict against the then Minister of Law and Order to try and stop torture in detention, and we failed miserably. My interdict didn't work. But I was working then in Alexandra Township, and in fact in charge of the pediatric department. We had a 6-day war, and many things will teach you things in your life, but you can't really prepare for what happens when young people are being shot all around you. And as we see today, when people are frightened and when they're injured, they seek care and protection in health services. And during that 6-day war, we tried to shelter many of these young people who had been injured. But again, we didn't win that battle, and many of them were removed. But at the same time, in Alexandria, it was a very large township north of Johannesburg. We saw South Africa had seen its first case of HIV in 1982, and in sort of a couple of years later, I think we thought, we couldn't test, but we thought we were seeing the first case of HIV in Alexandra. But what we were seeing definitely were vaccine-preventable diseases. We still had polio, and we had a huge measles outbreak. And my first publication was from a household survey done in Alex, which was looking at reasons why children were not being immunized and why we were seeing these outbreaks. And what we now know is that one of the biggest determinants of whether children were going to be immunized was maternal education. So moving on, and so one of the things that you have to think about is how do you jump from clinical to research and then into policy? And in fact, it was an extraordinary time, because at the end of the 80s and the beginning of the 90s, South Africa was looking towards a new country. And so we were putting together a health policy. And that health policy included women's health, child health, and HIV, and I was involved in developing all of those. And this was the meeting that was held in Maputo in 1989 between the external wing, the people in exile from the health desk of the African National Congress, and those of us working inside the country against apartheid. And then, of course, we had the democracy, Nelson Mandela, And I was asked to set up what was then called RHIU, which was a research institute, to address the neglect that had occurred. Research was not being undertaken very much on the majority of people in South Africa. And so I was asked to say, would I set up what was then very much focusing on reproductive health and rapidly on HIV. But to go back to social justice, the other thing that occurred, which was very important in terms of thinking about public health and social justice, is we had a Truth and Reconciliation Commission. Faisal was one of the Truth Commissioners, and we had an entire part of the Truth Commission dedicated to what had happened in terms of abuses around health during apartheid. But let me then go on to HIV. So if you look at the maps on the left, in the top left-hand corner, you can see in 1984, this was the density of HIV infection in the Africa region. And if you go down to the slide on the bottom right, you can see in 1999 that Southern and East Africa had become the epicenter. We undertook the first big national household survey in the entire country, and we sampled children, young people rather, aged 15 to 24, and we looked at their HIV status and what their sexual behavior was. And for the first time, we showed this extraordinary increase. If you look at the purple bars, those are young women. And we saw between the ages of 17 and 18 up to the age of 21 that we went shooting up to a third of young women being infected with HIV. But at the same time as this was happening, we also moved into an era of AIDS denialism. President Thabo Mbeki, the then president, and the late Dr. Mantu Shabalala Msimang, the health minister, just argued that HIV didn't cause AIDS, and as a result, they didn't want to have antiretrovirals in the country. But this was at a time when mother-to-child transmission was rife. We had no antiretrovirals, and a third of pregnant women were HIV positive. At that time, myself, and in fact, Precious Matsotso, who's here, we were both appointed to what was called the Medicines Control Council then. That was the Drug Regulatory Authority. And if you look at this photo, you can probably pick out Precious, and you can probably pick out me. And we went on from there to become, Precious became the Registrar of Medicines, and I ended up chairing this council. But we had huge pressure not to register antiretrovirals, but we did. We registered nevirapine for mother-to-child transmission, and we registered other antiretrovirals as well. And that was in the face of huge political pressure that we should not do this. Time ticked on, and I now chair the Drug Regulatory Authority. But during COVID, it was the same experience, that there were all sorts of different interests, commercial, lobbyists, etc., who didn't or did want particular products. And what that really has taught me in terms of governance is that the importance of independent medicines regulation. That in fact you cannot be influenced by anybody, and you have to look at safety, quality, and efficacy, because your job is to protect the public. So back to HIV and my institute. So we then said, well, we need to deliver services. The pressure was huge, as you can imagine, with so many young people infected. On the slides on the left-hand side, one of the earliest services we established was for sex workers. You can see that hotel at the bottom. These were brothels, and we had both outreach and clinic services for sex workers, where the rates of HIV infection were 60% plus. We also then moved through PEPFAR into providing support to government services in the middle pictures, but we also got grants to give services for HIV and TB to key populations, so MSM, transgender, and sex workers, but also to neglected populations at the bottom, people who will not otherwise access services. And those interventions have made, not just mine, but the national interventions made a huge difference over time to the HIV epidemic in South Africa. But importantly, we also had a huge program that focused on youth. This was called Love Life. We had interventions in all the provinces. We have 9 provinces. We had adolescent-friendly services, and when pre-exposure prophylaxis became available, we introduced it across the country into schools. But side by side with that, you then have to say, well, what is the research agenda? And this is more from the clinical research side. And we looked at pre-exposure prophylaxis. We were also looking at vaccines. That's proved much harder, but pre-exposure prophylaxis has really progressed. We needed to get the right drug into the right place and at the right time. And we started off looking at condoms, and I put a female condom there because we did a unique study, never to be repeated, where we kept washing condoms because sex workers told us they're very robust. We can reuse them, but we didn't know if it was safe. So we did studies where we had washing lines with female condoms along them, washed once, washed twice, washed 3 times, and we tested them. They were very robust, but we couldn't persuade WHO to approve a reusable condom. But we then also looked at topical microbicides, really focusing on young women, and we looked at gels and rings and films. Huge studies that we undertook, regional studies that were led by myself and my institute. Unfortunately, we were unsuccessful. What was much more successful were oral antiretrovirals, which proved to be partially effective. But a daily pill is a hard thing to take. So what has been really, really successful are the long-acting injectables. Long-acting cabotegravir, also led by a colleague in my institute, and lenacapavir, which is the latest product, which is a twice-yearly injectable. And we did acceptability studies, and people said, actually, we prefer to have an injection, something 2 monthly, something twice yearly. Thank you, we'll take that. So that's the good news. But the bad news is you then have to create access, which is the next step in getting products out. Long-acting cabotegravir is still not widely available, and when we looked at the costing, one of the reasons for South Africa is that it would have added 40% to the existing HIV health program, so it's not widely available. Lenacapavir is currently undergoing regulatory approval in many countries, including South Africa, and it looks like it's going to be more cost-effective than the long-acting cabotegravir because it's twice-yearly injection, and we think that adherence is likely to be greater. And if you look at the bottom, I'm sorry that the lines have jumped here on this presentation, but it is much cheaper per HIV infection, potentially in terms of cost effectiveness. The reason for looking at this is that there are so many steps that you have to go through before you can actually finally introduce a product. And this is a good example of the complexity of this. Just going to put one slide in on another approach, which is very important before you introduce products. And in parallel to HIV, we were doing a lot of work on other sexually transmitted infections and other infectious diseases. But I just used HPV vaccines as an example, because here we did a whole series of studies, starting with piloting the introduction of HPV vaccines into schools, where we looked at the feasibility. Remember the EPI programs for the sort of under 2s, under 5s, never introduced vaccines into schools before. Is it feasible? Is it acceptable? What do you communicate to the parents and to the teachers, and will there be demand? Side by side with that, and I'll come back to this, I was then working with various technical advisory groups on vaccines. The national technical advisory groups called NITAG, the regional technical advisory group, these are all WHO structures called the RITAG, and SAGE, which I'll talk about just now. But beyond that, we still saw that it was difficult. It's a 2-dose schedule. So we then developed a whole set of studies that looked at, can you give a single dose of this vaccine? It would free it from schools. It would mean that a single dose you can give widely and quickly. And we were able to show that a single dose in our populations was effective. And we also then looked at impact studies to demonstrate whether giving a single dose at a population level actually reduced HPV 16 and 18, which is what the vaccine is designed to do. And we were able to show that, including in young women living with HIV. So let me go on to global governance and vaccines. So in 2001, my clock is going backwards and forwards here, I chaired the first HIV vaccine consultation for WHO, and in 2005 I chaired a consultation on HPV vaccines. And as a result of that, I was invited to serve on the Strategic Advisory Group of Experts on Immunization, and Joachim is here, I saw him here, who actually facilitates that committee today. it has become one of the most effective WHO committees. And if ever we wondered about what WHO's role is, I think just take this as a case study. It is hugely effective. It makes recommendations about new vaccines. It looks at schedules of old vaccines and continues to look. And it makes widespread recommendations that take everything from cost effectiveness to programs into account. I also work with the Regional Immunization Technical Advisory Group, also a WHO structure, which takes a SAGE recommendation and regionalizes it, because each region, as you can imagine, is different. And because I was working in this field, I've had the privilege to work with a number of international organizations listed here for polio, International AIDS Vaccine, Coalition for Epidemic Preparedness, Gavi, the Vaccine Alliance, IVI, and we'll hear from Jerome Kim later, and NIH and NIAID. But my breadth of work has then expanded with my institute to this list here. And you can see much wider vaccine-preventable diseases, and spanning anything from the research, the clinical research, the epidemiology, through to the policy that's required. And at the bottom, you can see that there's COVID, extensive work there, Mpox, pox viruses, Ebola. And that brings me on to the issue of emergencies. And WHO has a unique role to play for emergencies. As you're all familiar, that there are the International Health Regulations of 2005. And after the Ebola outbreak in West Africa in 2014, there was a whole question raised about whether these are still fit for purpose. And I was on a committee that reviewed these regulations. At the time, we said they probably need modification. But everyone was too nervous at that time to take that step to actually change them, because we were worried that we didn't want to lose what we had in the IHR. As a result of that, I worked with the Polio Emergency Committee and the COVID Emergency Committee. And moving on to today, I'm working now with regional and national committees on Mpox. In South Africa, we have an incident management team because we have an Mpox outbreak. Africa CDC has an emergency committee, and we declared the first public health emergency of continental security for the African region for Mpox. And there is a new initiative from WHO looking at pathogen families that are a threat for future pandemics. And I'm involved with the pox virus initiative there. And that's all very good, but if you haven't got the money, it's a problem. So two other things I'm just going to refer to is the two organizations who are part of this incredibly important global health infrastructure that I've had the honor to work with. Gavi is one, that's the Vaccine Alliance. It's estimated that Gavi will have avoided nearly 19 million future deaths between 2000 and 2023 because of its innovation. Many of you here are familiar with Gavi, but Gavi basically subsidizes for the poorest countries vaccines and gives support for health services to support the introduction of those vaccines. It also has vaccine stockpiles for emergencies for things such as Ebola and yellow fever, and most recently is also offering support for African vaccine manufacturing, which was a huge demand from the African region after COVID. Away from vaccines onto a broader health product initiative is called MedAccess, which I also work with. And here, there is an initiative that says there are many products that are needed by low and middle income countries, but they're not going to get them because there isn't a high income country marketplace, whether it's new generation of malaria bed nets or whether it's multi-drug resistant TB drugs. And so again, MedAccess does volume guarantees, does market shaping, and creates an innovative financing offer that supports companies to actually become producers of these products that are needed in other parts of the world. So I've learned a lot of lessons. It's not quick learning these lessons. It's taken quite a long time. And really, there were sort of 10. 10 is always a good number. So it is really about identifying the problem, prioritizing a research agenda, and then looking for appropriate technology. Then looking at implementation science, policy, governance, finance, access, and community and trust. I've learned that, but let's just think where we are now. And here we have now devastating funding cuts that none of us were expecting, with huge implications. What we've had is sudden withdrawal. I think we would all understand and accept that countries absolutely have the autonomy, but the sudden withdrawal has caused huge pain. If you look at that graph at the top, you can see how important US funding has been for global health and global aid financing generally. And the US provided, of that amount, the US provided 30% of that was for global health. But equally, underneath, many European countries are bilateral donors, philanthropic organizations such as the Gates Foundation. That money is now under threat. So we are really facing a new era where we're going to have to think what we do. Replenishment targets are coming up this year for WHO, for Global Fund, for Gavi, for the Pandemic Fund. 100 billion is what we're looking for at a time where we're seeing these cuts. And we have now seen also huge cuts in research, in the R&D, particularly from NIH, that was responsible for half the global R&D research funding. So now, we should look past these events of today and into the possibilities of tomorrow. And as we do this, we shouldn't say, let's have faster horses. We actually need to look at a new model, which in this case was the automobile. And we need to rethink global health. And as we rethink global health in the context of all of these challenges that we're looking at, what should we be looking at? Well, we need to look at global governance, financing, health services, research, and leapfrogging technology. So global governance is currently being looked at, and the World Health Assembly has obviously been discussing this, but really to look at the roles and responsibilities of who does what. So who does what the best? Who should lead in what? What in particular is WHO's role, power, norms and standards, emergencies? WHO has a critical role to play. How do we strengthen that? But we need to streamline all of the global structures and funding, because clearly what we've been funding is not sustainable. There should be a strengthened, many people are arguing, and I would agree, a strengthened regional focus. We should be responsive to country needs, but especially the lowest income countries. We are going to have to prioritize. We can no longer do everything. And we're going to have to start to use, particularly in the low middle income countries, local versus global expertise. So if we're going to make the case for funding, how do we do this? This map shows the amount of foreign aid that's received as a share of national income. And the darker the green, the bigger the amount of foreign aid that's been received. But in this map as well, just note the comment at the bottom, over 50% of low-income countries are now at high risk of debt crisis. So how do we make the case for continued financing for global health? Well, first of all, I would say there's high returns on social investment. Immunization, maternal child health, incredibly high returns in terms of social development. There are many international benefits by funding global health goods, funding pandemic prevention, preventing the expansion of HIV in the African region. Remember, we've had a withdrawal of the PEPFAR program. If we have expansion of HIV in the African region, we are going to create a huge reservoir of immunocompromised individuals. And if we want to see emergence of new pathogens, that's exactly what you could do. So we have to also think, how do we stop that from happening? And we have to think again and in a different way about sources of funding. Richer countries, I would argue, should, for the reasons I've given above, continue with the ODA to give support to poorer countries. But countries, and you've heard this loudly from the African region, countries also need to look to themselves. Budgets need to be redirected for their own health services, but debt relief needs to come into this, noting what I've said there about over 50% of low-income countries are at risk of a debt crisis. Clever taxation, the sin taxes, the tobacco, sugar taxes can also be considered. But the development banks and multilateral organizations also need to rethink what is their model. Innovative financing such as Gavi and MedAccess can be expanded. Bilateral aid should continue, I would argue, for the poorest countries from rich countries. And philanthropy remains incredibly important. We also need to make the case for financing of research and development. And to start with that box on the right, this is just one example, that the return on investment for $1 invested for neglected diseases for R&D is $405. So you can make the case on an economic basis. And you can say to countries, but actually R&D is critical for your development, it's critical for your growth. You need to find solutions for your state, for your society. Culturally, reputationally, this is a good thing for a country to do, and the return on investment. But for global investment, we still need to make that case. And I would say that one of the ways to make that case is to say, well, you're contributing to global development, which makes everyone safe. That there are shared global benefits, such as pandemic research, and that actually, if we all work together, we will accelerate technology development. And then there's the feel-good factor. I think George Bush was hugely proud, as he should have been, about initiating PEPFAR. There is a feel-good factor for rich countries to be able to assist. We need to look at the other end of things, because we can't just consume and consume. So we need to improve health systems. We need to go from the bottom up instead of the top down and have country-driven priorities, patient-centered services, integration of services, HIV and chronic diseases. They now go together. We need to redesign, we need new tools for self-care and management. We need to get patients out of the clinics, because the clinics are overcrowded and under-resourced. Give people tools that they can manage some of their own diseases, even in low-resource settings. We must redesign health products for ease of use and delivery, and I'm going back to lenacapavir. Twice a year injection is much easier than people coming every month to get tablets to take every day. Cross-border sharing and surveillance is absolutely critical if we're going to consider outbreaks and pandemics. And then we need to leapfrog technology, and particularly improve connectivity, electricity, and artificial intelligence. So leapfrogging technology, there's been a lot of discussion at this World Health Assembly. This is going to be cost-saving. Every model you'll see with leapfrogging technology using AI for health shows cost savings. You increase health worker competency. You can do it remotely. You increase the accuracy of patient diagnosis. You can therefore have early detection and surveillance and response to outbreaks at a much earlier stage. If you digitalize everything from a facility to a district to a national level, you get incredible data sets that will help you respond to what your problems are. And you can respond to patients' needs. And we're already using chatbots in languages so that people can ask their own questions and really understand what it is that they need. And you improve self-care. And finally, as we rethink this, I would also argue that we need to rethink community engagement. I think that we've become complacent about this. On every proposal you write where you're doing funding, you talk about community engagement as the last tick box. But do we really know what we think? We need a new vision for community engagement in this current context. And we need to reconsider, I would say, the activism model. It can't only be oppositional. I think now we've matured, and it must be driven by communities, but it must also be done in partnership with health services, with ministries of health, and with the private sector. We can do things together, we can oppose when we need to, but we do need to also rethink that model. And, very important, we need to create a much better understanding of science literacy to build trust in science, but trust in medicine, which has been eroded during COVID, vaccines in particular, and we have to counter misinformation and disinformation. And this diagram on the right is from Nature from this year, which indicates that a large multi-country survey, still people trust scientists, about 2/3, but people more likely to go to family and friends for guidance. So we need to think, who are the messengers that we want to get these messages out so that we can actually rebuild that trust. So finally, let me leave you with this quote from Nelson Mandela, and it's a quote for today. "Do not judge me by my successes. Judge me by how many times I fell down and got back up again." I want to thank so many people that I spoke to. I told you I was neurotic about giving this talk. It's a very difficult talk to give because you're reflecting on yourself. So I spoke to lots and lots of wonderful people and asked them, what is your view of where we are today? And got incredible feedback. And I'd like to thank everyone who's listed here. I'd like to thank very much the honor of from the Korean government and the foundation for awarding me this prize. I'd like to thank all the participants. I've done lots of research over the years. I've got many colleagues I can see in the audience who I'd also like to thank, who are not only colleagues but friends, but have taught me such a lot. The donors who I've listed have been hugely important. And we should never forget that. And even if they're reduced or gone now, I want to say thank you for what they've given us. And the many colleagues who are continuing the struggle for global health. And finally, I want to thank this lot, who is my family. I've got extra extended family here, but this is my family here, who have been incredibly supportive to me in my career and tolerated, as Precious said, my long stays in airports. Thank you very much.
Thank you, Helen Rees, for your inspiring and deeply moving lecture. We admire your research and we love your activism. Your work and dedication to public health have truly touched and inspired all of us today, as we can hear. Now we turn to the second part of our program, the panel discussion, entitled The Future of Global Health. And I am honored to co-chair this important session alongside a truly distinguished colleague, a very good friend, Margaret Chan, former Director General of the World Health Organization. Her visionary leadership and decades of experience have left an indelible mark of global health. Together, we look forward to engaging in a rich and meaningful discussion on the challenges and the opportunity that lie ahead of us. So, over the past few years, the world has faced unprecedented public health challenges, from the COVID-19 pandemic into the growing threat from climate change and rising health inequities, as Helen mentioned a couple of times earlier. Today's discussions offers an opportunity to reflect on these lessons and to explore pathways toward building stronger, more resilient and equitable health systems. Before we dive into the discussion, let me introduce our three distinguished panel. Our first panelist is, of course, Dr. Helen Rees, Executive Director of the WITS Reproductive Health and HIV Institute in South Africa, and our esteemed laureate of the Dr. Lee Jong-wook Memorial Prize for Public Health. We will have Dr. Jerome Kim, the Director General of the International Vaccine Institute. Dr. Kim is a renowned expert in virology and vaccine development, working tirelessly to promote equitable access to vaccine worldwide. And finally, we welcome Dr. Suraya Dalil, the Director of the WHO Special Program on Primary Health Care. Dr. Dalil has dedicated her career to strengthen public healthcare system and advancing health equity, particularly in fragile settings. So please, you can come on stage, all of us with me, the panelists, Margaret, Helen. In the middle. Margaret, the floor is yours.
Truly a great honor to be here. And Helen Rees, I know you through and through, right? Thanks for your contribution to the World Health Organization. And of course, Suraya, thank you. And Dr. Kim, last but not the least, you're the man, the most important person in this forum, right? My dear friend, Anton. Over to you. Now, the first question I like to pose, given what Helen has told us, what is the future of public health? That is my first question.
So, who wants to start?
I could refer to my last slides at this point. Well, I think, as I said, I think that we are definitely going to have to regroup. But I don't think that we can say, let's do the same, only on a lesser scale. I think we have to restructure. And we have to say, which pieces do we restructure? And it has to start by saying, what is it we want to achieve, and what is going to give us the best return on investment? Things like immunization, maternal child health are obvious. But we're going to have to, as I said, rethink how we deliver health services. Integration, but also better technologies, so that we've got smarter technologies, easier to administer, easier to store, easier to transport. I mean, everything that is going to make health services better. But I do think that at the global level, the global health ecosystem needs to be reconsidered. Because if there isn't going to be money, we shouldn't be trying to run things on a third of a budget. We should then say, how do we consolidate? How do people work smarter and together? And what is that ecosystem going to look like that plays to strengths?
Okay. Now, before I give the floor to WHO, I would like to invite Dr. Kim. What do you think? The future of public health?
So it's hard to follow one of your personal heroes, but I think since the year 2000, and actually since the 1990s, we've made such incredible progress in global health. Children are alive today who wouldn't have been alive. People are living with AIDS, are dying with AIDS, with HIV rather than of it. These are really remarkable advances. We don't want to give up the advances, but at the same time, we have to face the realities of maybe a restructuring of the way we had funded this. I mean, we're living in an age where official development assistance has been a tremendous contributor to a lot of the success. And you can't just replace it, as Helen said, overnight. And actually, one of my colleagues said, well, we're entering a new age, an age where ODA is still important, but there'll be less of it. So what do we really need to do? And I think Helen captured this in saying it's going to now be regional and national, and countries, individual countries, including some of the countries receiving development assistance, will need to have a stake in the future of where we're going in global health. And is this new age necessarily worse? No, actually, because in the end, countries are responsible for the health of their individual citizens. And this is maybe the first, it's not a push. We have to consider what was done to be a lot worse than that. But it's going to be a reminder. And as we regroup, rethink, and find and fill the gaps, exactly as Helen said, think end to end. So we have to really think through a process. We can't just have a vaccine. We have to have a plan to use it. We have to know that it's going to be cost effective. We're not just developing vaccines, again, to use my area of expertise, we're not just developing the vaccines for the companies, we're developing them to be used and to have impact. And then finally, this idea of cooperation, removing redundancy. Because there is redundancy. In a time when there was a lot of development assistance, there are overlapping capabilities, and we really have to be careful about that. And then prioritization, and that's a horrible word. But it's one where we're looking at what we need to preserve, what we have, and what we can do better. So thanks.
Okay. WHO, you are having a difficult task.
Absolutely.
With the migration of the agenda, everything comes to you.
Yeah.
Now we are faced with the CD, NCD, innovation, AI, and the bread and butter stuff like maternal and child health, and the list go on and on and on. So how are you going to make the ecosystem work?
Great.
First, it's an honor to be here and to be among the distinguished panelists. I want to speak on behalf of WHO at the beginning, but I would like to also reflect on my own ideas. Coming from a low-income country, from a fragile and a very, very kind of humanitarian setting. So first, I was really happy when I saw in your slides, Professor Riss, about the definition of health according to the WHO's Constitution of 1946. You say that health is a complete state of physical, mental, and social well-being, and not merely the absence of disease and infirmity. And I think that definition of health is as valid and important today as it was 76 years ago. So when we look at health, and we look at health from a holistic perspective and not merely the absence of disease and infirmity, then as long as human being exists on the planet, we need health, and we need health agenda, we need institutions, we need entities, bodies that uphold health and work towards health. So that's my first reflection with regards to health. The second reflection I would like to have is on gross inequalities that exist in today's world. We are in 21st century at a time where we send to space. We are able to go and put our foot in few planets outside our own planet. We are in a situation that billions of world population are connected with digital technology. We are in a situation where family members sitting in North America speaks to family member who is in South Sudan. But yet you see that there's a gross inequality in terms of very, very basic services, be it immunization, be it antenatal care, be it services for elderly population, and so on. Or women dying from childbirth. Basically, I'm coming from a country where every 2 hours, I'm coming from Afghanistan, and that's why I would like also to reflect on that. So don't take me only as a WHO representative, where every 2 hours a woman dies from pregnancy, merely from hemorrhage. A lot of it, 2/3 of it is from hemorrhage. And you wonder that despite all those progresses that we have made in the civilization of human being, where is that equality among nations? Where's that equality among societies, among communities, and how rich countries can help countries that are poor? So I would like to go back to the global health discussion, and that discussion is that how the future would look like. I think the future to me would be, first of all, we should all accept that the system we have so far is the right time to change. It's the right time to revisit that, and it's right time to set the new direction and the new path for the bodies, for the entities, for the institutions to respond to the population need. There are things that we need to consider into that one, and the first and foremost is national ownership. The national ownership, the countries must take responsibility for their population. Health cannot be a give and take relationship. It's like, come, provide aid, then go, and the aid will drop, will decline, or whatever. I think that model, that design is not going to work. We are in a much complex world where we have people who have comorbidities. We have situations where people do not have access to water and sanitation. We have situations where people do not have access to food. We have situations that people do not have, live with less than $1 per day. So I think the issue is that national governments should take more and in a genuine way. I'm not talking in terms of really like kind of high-level speeches, and in a genuine way take more responsibilities for health and for international entities and bodies to listen to the government and to national, and for the national government to listen to their population, to listen to their citizens, and that's where active citizenship comes in.
Okay.
In that, I would also like to put women in that equation. I would also like to put young people in that equation, because no matter what, they are the stakeholders in healthcare and in provision of health. I would just last point, and I would really like to say that, and that's war, because in one of your slides you said it's about war and it's about fighting, it's about conflict. We should also do something to stop that. I think it's important that the war should be stopped, and because there is, the scale of the injuries you see, that's human-made injuries and traumas and opportunities that are lost for millions of people because of conflict and because of human-made war and battles, all sorts of things.
You open up a can of worms. I fully agree with everything you said, all the speakers. It's very important, right? But with such a budget cut, where is money coming from? Everybody needs money. Research needs money, all the important issues you talk about, and all the alphabet soup, Gavi, CEPI, and Global Fund. Come on. We need to talk real. Okay, to talk real, I pass it to Anton.
Jérôme, I have a question for you. During the pandemic, we have seen a lot of inequity in the distribution of vaccines, of the COVID vaccine. The rich countries had, and the population in the rich countries had more vaccine than they needed and they used, when the poor countries had very late, very few doses, and in fact, despite of the great mechanism like COVAX, which tried to do more and to do better, we did not succeed. We failed. What do you think? How can we ensure better equity between countries, maybe to try to solve pragmatically in this case of vaccine? How do you see the future of a better equity in vaccine distribution in case of a new pandemic, for instance?
Are you asking me?
To Jérôme. Or maybe to you, Margaret, of course.
Well, let's talk real, okay? Vested interest, isn't it? At the end of the day, every country is doing the right thing. But when you look at, in totality, they are doing the wrong thing. Isn't it? Countries that have surplus vaccines, and Africa has nothing. So, when I was Director General at my time, it took 10 years for any innovation to go to Africa. And I keep asking the question, why? It has never been answered, right? Why does it take so long? Now, hopefully, AI this time is going to help us. You look at DeepSeek. It has changed the world because it is much more cost effective. The developing country think that they could not afford, but because of the arrival of DeepSeek, AI is open to all. Now, can we do the same with other medical products? Over to you.
Jérôme Kim, do you want to comment on that?
Yes, so I think, when we look back at the lessons of COVID, and it's still not too late to fix some of these problems. I mean, it starts with research funding. I mean, CEPI, which did a remarkable job, the funding that it pushed out in the first 3 weeks of knowing the sequence was responsible for the generation of at least 3 of the EUL projects. But none of that funding went to the companies that make 60% of the world's vaccines. And why? I mean, if you wanted to make 2 billion doses, wouldn't you go to the people who make 2 billion doses? And none of that money went there. And I think that CEPI is gradually beginning to adjust to the reality of where vaccines are made. I think that the second question is actually a national one, because it turns out that it's not only the United States or Europe, but other countries have laws that prevent vaccines that have been purchased from being used on the basis of a national priority. So we saw that with the AstraZeneca vaccine, unfortunately, which again delayed access. The third part is, actually, and where a lot of people were critical of COVAX, but Margaret makes the point. The rotavirus vaccine was approved in the US in 2006. It was approved by WHO and recommended in 2009. Now in 2025, 60% of the world's children still don't receive all the doses of rotavirus vaccine. So the standard of care is that it takes 20 years before a vaccine really becomes used in countries that need it. COVAX and the other, the mass production of vaccines during the pandemic, 70% of the people in this world in the first year of introduction got at least 1 dose, which isn't right because the countries that needed it got it late. But maybe it means that COVAX just needs to be tweaked, and the time to fix the problems is not in the next pandemic. The time to start thinking about how to purchase, when to purchase, and how to distribute quickly is now. Why? Because we had an Mpox outbreak in DRC. It's ongoing, but we had FDA and EMA approved and a vaccine approved by the Japanese regulatory authority. All ML4, stringent regulatory authorities. We couldn't use it in DRC. Why? Because they weren't yet ready with the EUL. And, as we're thinking about these things, let's take the individual cases where things haven't worked and fix them so that the next time there's an outbreak, that vaccine can be used quickly. It doesn't have to wait 3 months for a meeting that will then authorize the use of the vaccine. And then the final thing is, and I think this was addressed by Helen also, I mean, in the end, it's about giving the vaccine. And there were instances during COVID, and actually even now, where there's a huge amount of vaccines sitting unused because the systems are not in place to be able to distribute the vaccines. Now, to some extent, that can be improved with improved mechanisms of delivery. So do we depend on a cold chain of -70? Or do we have one that works at 40 degrees centigrade? Do we have ways to give things that don't require a nurse to stick a needle into a patient? And if we do, then can we get them tested and approved more quickly so that these new technologies can be used and deployed rapidly in the case of outbreaks? So again, thinking through a comprehensive solution, I think, and it's possible, and it's not going to cost, I forget the number that was put up, Helen, $50 billion, $47 billion. I mean, these are not expensive interventions, but as we think through what we need and prioritize them, we should focus on them.
I think just coming at it from another end, what happens when you don't deliver has broader repercussions. So what's happened I've seen, but for both pandemic flu, when we had pandemic flu, and we got vaccines very late into the African region, and then with COVID, is that the population then just shrugs its shoulders and says, well, thanks and no thanks. You've been there, we don't want it, it's too late, and we won't have it. And then you have a secondary ripple effect, is that people then lose faith in the system, in the health system, but they also lose faith in this instance in bothering with vaccines. So the knock-on is quite extensive. But I do think that we need to go back and look at, as we look at the whole ecosystem, what are the models of innovative financing that would allow us to actually get some of these products out. I mentioned Gavi, I mentioned MedAccess, but there are other innovative ideas around how do we co-finance and get things out there. I think one of the things we haven't talked about, but as we're thinking of co-financing and we're thinking about pricing being a huge block to access, is if the US does go ahead and push down prices significantly for pharma products, and you can understand why US citizens would say, actually, it's a bit unfair what's going on here. But it could change the entire pricing structure of the world. Because if pharmaceutical companies cannot get margins in high-income countries, their incentives to lower for low-income countries is lessened, the financial incentives. So we also need to think about the financial model that we have in place now and have some scenario planning in case that financial model changes. Lastly, after COVID, there's a huge excitement from the African region, led by the African Union and the heads of countries, to say, actually, we now demand our own manufacturing. And there's a lot of innovation, including from Gavi, from others, in terms of vaccine manufacturing in the African region, but not only vaccine manufacturing, but other health products. I think that the problem is that particularly for something like vaccines, that's not a quick fix for most vaccine technologies. mRNA might well be easier, but it's not necessarily going to be a solution for all vaccines. But I think the issue about vaccine manufacturing is one we definitely need to promote so that we do have access in regions to products. At the moment, as we know, less than a very small percent, less than 1% of vaccines that are used in the African region are actually manufactured in the African region. Similarly for pharmaceuticals, very little of our pharmaceutical products. That's a medium-term fix. That isn't a quick fix. So, and we have pressures here. And I think one of the things for the pandemic treaty has tried to do is to say in the event of an outbreak or an emergency that we start to conserve and dedicate a percentage, 10, 20%, that we dedicate those percentages to low-income countries who will not otherwise get access. And I think that's going to become a very important clause if we can implement that.
To Margaret, maybe. Is it Michael?
Can I ask Precious a question? During my time, there was such thing as what we call PIP, and a certain percentage is dedicated for developing countries. Now, I was told that it has moved PIP to something else. So, well, it is important that the increase in the quantum, financing for developing country is much better. Now, can you help us?
No, thank you very much. I think Helen is right, but I think we probably need to also look at this comprehensively, to look at a technology transfer, a diversified production, because there's an understanding that it's not every country that will produce every single product. So the regional approach to production of vaccines, therapeutics, or diagnostics, I think is the way to go. In relation to what Helen was saying, is that the pathogen access and benefit sharing is modeled based on the PIP framework, as you correctly say. But of course, we need to understand that PEEP is very specific for seasonal influenza. And here we're not dealing with a diversity of pathogens. And we don't know what kind of outbreaks we're going to be dealing with. So much as we took a leaf from the PEEP book, it has to be carefully considered on how the modalities and the terms and how the operational dimensions are going to unfold. But I think the lessons were learned from the PEEP framework, and Helen is right. It's actually going to be a game changer on how we make vaccines, diagnostics, as well as therapeutics available. And those percentages, which are referred to as set-asides or allocations, were also lessons based on lessons that we learned from the PEEP framework.
Thank you, Precious, for what you have done, okay?
I have a question to the panelists now, but if there is any question in the audience, please feel free to tell. There are some microphones. We will listen to you. Just before, to the panelists, I would like to come back to what Margaret mentioned about artificial intelligence. It's a game changer, for sure. My question is, do you think we would need a kind of protective agency, something like for the drugs? For the medicines, we are interested in their efficacy. They are game changers in many diseases, but we are also interested in surveillance of the safety, of their safety. Do you think for artificial intelligence we should have the same for public health, for human rights and confidentiality and all these things? Do you think we should also have a protective agency at an international level regarding the use of AI in health?
I think so. I think but I don't think we've worked that one out. I mean, when we talk about redoing the global infrastructure and the ecosystem, I don't think we have included that as a considerable. We're talking about what we currently have and how we rationalize what we have. But I think that the advantages, as we've listed, I mean, I listed the advantages to the health system, the advantages to using AI to the development of new drugs, new vaccines, is absolutely potentially enormous. But there are many things we don't know how to do. For example, we don't know how to regulate those products. I mean, regulatory authorities won't know how to evaluate something that has been where the scientific origin has come through AI. How are we going to do that? So I think that, I mean, this is obviously something that's getting enormous attention. But certainly there are ethical questions. There are, as you say, protection of individual rights and privacy. But there are also questions on the other side of it about technology development and how do we ensure safety. So I would agree with you that we will need to have some structures. I mean, for sure, WHO has got and will need to expand what its thinking is. But many of I know, for example, the Gates Foundation is investing a lot in AI technology, but they have a committee that's looking at the ethics of their investments in AI technology. So there are many people are thinking about this. Do we have one cohesive global solution? No. Is it being considered at the moment in this global ecosystem that we're rapidly trying to rationalize? I would say not. But should it be done in the next year or two? For sure.
We have hands up. I can see two hands. One from a woman. Okay, can you all come to the front and line up?
You need a microphone.
So, first, Helen, congratulations. This is spectacular and you deserve it. I just wanted to comment on 3 points. The first one, and this is not all my work, but I think it's important for the audience to get some of the facts. Number one, WHO is working on artificial intelligence, focusing on equity, a legal framework, and it's used for health, and there are just World Health Assembly resolutions that were endorsed by our member states, 193 of them, that will help to frame for the future how we can benefit and have an ethical approach that with access to everyone for artificial intelligence. The second one is about the country's work, and my colleague explained a lot from the community health perspective, but I just want to say that also in the pandemic treaty contents, there are clear items of discussion by our member states again that clarify several of the points that you referred to. So I will invite everybody to read the content of the pandemic treaty because it addresses almost all the points that we are discussing today that were discussed at length. Access, how to ensure that equity is not equity and distribution of products at the very end, but it goes with equity in generation of knowledge and access to research information. There are also the challenges because if everybody sets up a manufacturing facility, then the sustainability issues will kick in, and all this has been discussed. And the third is about the importance of collaboration. The pandemic treaty, as Dr. Tedros says, demonstrated that multilateralism is alive and well, and we should not retrench to work only on local things. I agree with my friend Helen that countries should work together, but there are scientific issues that should be addressed in a global way. To improve the health of others. Most of the diseases we talk about are not local. Most of the diseases of the 1,654 viruses that can cause the next pandemic are viruses that go across the continents, and collaboration is important. This is why we are very happy Helen is coordinating one of the collaborative open research consortiums for science. And then the final thing I want to say is that some of the issues of vaccine uptake have to do with what you mentioned, but also with local priorities. Helen alluded to that. Sometimes we think that the country should introduce a vaccine, but that country has other challenges of health that makes them make other decisions. So if we are going to work to increase the capacity of countries, we also have to learn to accept that their priorities sometimes will be different to ours at regional or global level. Thank you.
Hello, my name is Robert Matura. I'm the Director of Programs at Unitaid. We're a health innovation agency. Good to see you, Dr. Channon. Congratulations, Helen. Couldn't think of a more deserving recipient of this award. I just want to draw on a couple of things that you showed in your really excellent lecture to answer your question, Dr. Chan, which is a real challenge. You're saying we need to do all these things, and yet we have less resources. But in effect, what we are doing at Unitaid and working with our partners to start to identify, in fact, the resources there, they're just coming from different places. And if we simply say that we need to do things more efficiently, then the question is, how can we do that? And we saw in COVID that we were forced by the worst pandemic we've seen in a century to do things very differently and accelerate the development of life-saving vaccines in a very short time. And this crisis that we're facing now is actually compelling us to do the same. Sadly, as you said, Jerome, it happened very brutally and abruptly, so it's happening under immense duress. But it is forcing a shift in the direction we need to take around efficiency and simplification. And one example you presented, Helen, just illustratively, is long-acting prevention for HIV. Because when US funding stopped and PEPFAR's funding was pulled out from so many countries, more than commodities, life-saving commodities, was the money for healthcare services and delivery. But if you can have a long-acting preventive technology, 2 injections a year, you're going to start to address that problem. So the point we're trying to emphasize is we need to continue with the things we have and accelerate their use. But as Helen's slide showed, we can't just ask for faster horses. We have to continue to invest in the pipeline as well. Because I've been hearing, and we've been hearing that, oh, in these circumstances, innovation is a luxury. Actually, it isn't. Some innovations, which are far upstream, yes, we have to keep working at those and see how we reprioritize the funding. But others will actually make the transformations that will enable us to account for the fact that there is less money from the sources we relied on in the past, but we can get better efficiencies by using those innovations. So I might be stating the obvious, but I just wanted to re-emphasize that drawing from Helen's slides. Thank you. Next.
Can you hear me? Right. The excellent panel. Some of them I've pleasure and to have worked with. My question is to the panel, is there a future for global health without real public health and without primary health care. I emphasize the real public health and real primary health care because we can use terminology in different ways and there's a lot of jargon and things, so the proper principles. The second question is this the right time to discuss future of global health, or we might have to wait? If you look back historically, the greatest achievement in public health was the end of wars. And Dr. Dalil said that. Maybe we might have to wait for the end of wars. When you reflect the last 2 days, what has happened, it's very shameful. And many things happening today, whether it's Sudan or other places, it's very shameful. Are we ready to stop? The other question is, can we go ahead for the future of global public health and primary health care without doing a truth and reconciliation commission to look what was done right and what was not done wrong or what could be done better? Why I'm saying that is today there's a trust has been lost in the UN, WHO, for example, or even our governments, may it be any country, there's no trust. The people have lost trust and faith. And you must ask the question, why? The answer is very simple. Nobody is delivering services to people, with the people, by the people. The foundations of primary health care. We are not delivering services. We're just dropping products. We're dropping many things on our people, but we are not delivering the urgent services they require. So we need to look at why are we not delivering the service. It's not money. And it's not commodities. Thank you.
I can say that we are not delivering social contract, true or not. Countries are not delivering the social contract that they have signed with the people that elected them in office. So, you are right. You open up another can of worms. This is even bigger and more fundamental. Okay.
Thank you. Thank you, Chair. Probably we are sitting next to each other, might be the question is also infectious. I am Amitavo Sarkar from Tampere University, Finland, Department of International Public Health and Epidemiology. Just a question to all the dignitaries. First of all, congrats to Professor Helen Ellis for the winning. It's really an honor to talk in front of the panel. I just go back, if I can recollect it, in 1987 or 86 in WHO Bulletin, Dr. Malhar made a single-authored contribution on the muddy path of PHC. And if I go by the historic Almaty document of 78, the 8 elements, is it really possible? Because see, politics and regime, they are always, they have their own interest and all. Is it really possible to have so much of bureaucratization? So from the program aspect, global health, all the programs, all the interventions can be developed based on the foundations of PHC. In fact, I again recall when Dr. Chan launched the USC, probably 2008 or 9 or 10, Dr. Malhar came that PHC comes back to the full circle. So the design of program, if it can be based on the 8 elements of PHC, and what the panel thinks, what are the threats in terms of this in the future of global health. Thank you all.
Okay, can I add one more? Okay, So thank you so much for this panel. This was truly excellent. And my name is Christine Garuya. I'm an associate professor with affiliations at Stanford and Yale University. So I'm an academic. I've been doing research for NCDs for 10 years. So if I may just slightly change the conversation towards NCDs for a moment, with Dr. Chan, of course, having the first ever high-level meeting on NCDs and the fourth coming this year, could you kindly speak to real discussion, real answer on how NCDs fits into the future of global health in terms of financing? And if I may be a little instigatory, sort of this argument that it's going to come up with primary health care or UHC, but we haven't achieved those, and there's sort of a long road to probably achieving those in a real way. So comment on NCDs and how it fits into some of your discussion on the future of global health. Thank you.
Yes, thank you. I want to have a few reflections. First, about your question, Dr. Chan, on financial resources, that from where funding should come. Director General Dr. Tedros, in his opening remarks this week on Monday in the World Health Assembly, said that, which comes to the funding, he said $2.1 billion, which WHO needs for his next program budget for next 2 years, is equivalent of global military expenditure every 8 hours. He also said that $2.1 billion is the price of one stealth bomber. One bomber. That $2.1 billion is 1/4 of what the tobacco industry spends on advertising and promotion every single year. So I think when we talk about financial resources and the need for financial resources, and we put that in proportion to the rest of the world and to the other realities that's happening in our world, we need to make a sense of that how much financial resources we are talking about and for what in comparison to other spending that are being made. And I also like our dear colleague who really made my reflection easy on primary health care. In terms of how the future would look like, is we need to go back to fundamentals. We need to go back to foundations, and one of that is primary health care. As health systems that are oriented, that are designed based on primary health care approach. And by primary health care approach, I mean the services that are closer to the population, that population go and receive them, population trust them, and there's a relationship between provider and the recipient and the population. But I also mean communities engagement, communities empowerment, people to have a say in what they receive, accountabilities, that they ask for better services, they ask for more financial allocation to the health services, but they also ask for accountabilities. So when we say primary health care, we are not only talking about services, which is critical, and I'm coming to that, but we are also talking about people's role, citizens' role in that one, that kind of relationship, the trust and the social contract, which is supposed to be between the people and the government. So I want to say that another audience, asked about NCDs. I think when I say we go back to fundamentals, I mean that we go back to a situation that we have a primary care, no matter which countries that might be. It might be my country, Afghanistan, it might be Sudan, it might be Australia, it might be Fiji, etc. But then you imagine that a woman comes with a child to receive vaccines. And that's, of course, important, that's excellent, but the mother comes for vaccines, but we also need to make sure that the child is screened for nutrition. The child has been screened for other diseases if there's other complaints. And the mother also receives services that she needs. Probably she needs contraception. Probably she needs anemia treatment. But also, if grandparent brings a child for immunization, maybe the primary goal is to go and to receive vaccination against measles or pertussis or TB, but also
the grandparent need at that point. Diabetes, hypertension, cancer. So I think we need to go back to the fundamentals. We receive new vaccines, new technologies, but the delivery for that to happen for the billions of population around the world is primary health care. Unless we do that, and unless we do that in an equitable manner and prioritize that way. So future primary health care is imperative. What we need, not only financial resources, we need courage, we need commitment, we need political commitment, we need political courage, and we need our health priorities like primary health care and universal health coverage and health system should be able to survive the political turnovers, the political mandates over governments, etc.
Well, I think it is my prerogative as the former Director General of WHO to end on time. So we have to end at 3:30, right? We are here to celebrate Li Zhongwas, okay? He was instrumental in bringing me to public health, global public health. I want to thank him. Thank you.
Thank you. Thank you all, to all of you, the panelists, our distinguished lecturer, Hélène. And before we close, we would like to give to the president of the Korea Foundation for International Healthcare the last word for the closing remarks. And thank you everyone for coming and participating.
Thank you, everybody, especially Dr. Hélène Rhys, for your thrilling and really moving address and lecture, and all other panelists and audience. In fact, we don't have enough time to discuss more. I'm so sorry about that, but we have a limited time of schedule. So we have to stop here, but I think we are going back home with all the questions and agonies we have and discussions today. And I think though the problem is not easy to solve, and many, I believe we will get it if we really want it and we collaborate together. Thank you very much for your hard discussion. Bye.